If you've ever watched a parent or grandparent slowly slip away into confusion, fog, and forgetfulness, you already know how terrifying that journey feels. But what if I told you that in many older adults, what looks like early dementia is actually being caused and driven forward by the very medications sitting in their medicine cabinet right now? Hi, I'm Dr. Thomas Reynolds. I've spent more than 2 decades working with adults over 60, and I want to share something with you that I wish every senior, every adult child, and every caregiver understood before a single prescription was ever written. Today we're going to walk through 9 common medications, many of them prescribed every single day, that can quietly trigger rapid cognitive decline that looks exactly like dementia. Some of these are over-the-counter. Some are sleep aids. Some are bladder pills, acid blockers, anxiety medications, and nerve pain drugs. And the most important thing I need to say up front: this isn't about fear, and it isn't about stopping your medications on your own. It's about awareness. It's about knowing what questions to ask your doctor so you can stay sharp, stay independent, and stay yourself. By the end of this video, you'll understand how 9 of the most common drug classes used by older adults can mimic or accelerate dementia symptoms, why seniors are far more vulnerable than younger adults, what to ask your prescriber at your next visit, and which combinations become especially dangerous when used at the same time. If you're a senior watching right now, please put your age in the comments. I'd love to know who's listening. And if this helps you, please consider subscribing, because we're going to keep covering the truths that protect your independence. Let me start with the most disturbing part. There's a phenomenon in geriatric medicine sometimes called pseudomenticia, and it isn't fiction. It's a real clinical pattern where a patient develops confusion, memory loss, slowed thinking, even visual hallucinations, and the family assumes Alzheimer's. But when a careful medication review is done and certain drugs are tapered, the mental fog lifts, speech returns, memories come back. The person who was being prepared for a memory care unit goes home, sharp again. That pattern recovery that feels impossible happens more often than most people realize, and it almost always begins with one of the 9 medication categories you're about to hear about. Number 9 on our list is something most seniors don't even consider a medication: the old-fashioned sleep aid or nighttime cold pill, diphenhydramine, doxylamine, chlorpheniramine, hydroxyne. These are first-generation antihistamines, and they are anticholinergic. That means they block a chemical messenger in your brain called acetylcholine, the same messenger your brain uses to make memories, hold attention, and process new information. Think of acetylcholine like the wiring inside a lamp that you're trying to keep lit. These drugs quietly snip a few of those wires. Not enough to notice on day 1, but over weeks and months, the lamp starts to flicker. And because these drugs are sold as Tylenol PM, Advil PM, Zizquil, Unisom, and dozens of other sleep and cold combinations, many older adults take them every single night without realizing they're building a measurable anticholinergic burden inside the brain. The sedation feels like sleep. The fog the next morning feels like aging. Neither label tells the truth. Number 8 is a class most people associate with depression, but in older adults it's often prescribed for nerve pain, for migraine prevention, or even for sleep. I'm talking about tricyclic antidepressant amitriptyline, nortriptyline, doxepin. They are old medicines, they work, and they appear on the Beers criteria, a list of medications that older adults should generally avoid or use only with great caution, precisely because of their strong anticholinergic profile. In a younger adult, the brain adapts easily. But in a 70 or 80-year-old brain, even a small dose can produce dry mouth, blurry vision, urinary hesitation, constipation that won't quit, and a slow dimming of cognition that families often blame on getting older. The drug didn't cause Alzheimer's. It dimmed the lamp, and when the dose is reduced, that lamp can brighten again, sometimes within weeks. Number 7 is one most people would never guess: muscle relaxants, cyclobenzaprine, methocarbamol, carisoprodol. They are widely prescribed for back pain, neck spasm, and old injuries, and they do relax muscle. The problem is that the muscle relaxant you took last night also reaches your brain, and at geriatric doses it behaves very differently than it did when you were 45. The brain becomes sedated, reaction time slows, balance gets a little weaker, and memory consolidation during sleep is reduced. Picture sleep as the night shift repair crew for your memories. A muscle relaxant can quietly send half of that crew home early when they should be on the floor. Working for seniors, especially anyone who has already had a fall. This is a class where the risk frequently outweighs the benefit, and where non-drug options, gentle stretching, heat, physical therapy, careful posture work deserve a real trial first. Number 6 is one you've almost certainly heard of, even if you've never worried about it. Proton pump inhibitors. Omeprazole, pantoprazole, esomeprazole, lansoprazole. They are used for reflux, for heartburn, and for ulcer protection, and millions of older adults have been on them for years without a second thought. Observational. Research has consistently raised the question of whether long-term use, and I'm talking years, not weeks, has been associated in some populations with a higher risk of cognitive decline and dementia diagnosis. The exact mechanism isn't fully settled, but plausible pathways include reduced absorption of vitamin B12, depletion of magnesium, alterations in the gut microbiome, and increased low-grade inflammation. None of this means PPI use is bad in every case. Heartburn is real, ulcers are dangerous, and PPIs save lives. But the rule in geriatrics is clear: the lowest effective dose for the shortest duration that still makes sense, reevaluated every single year. If you've been on a PPI for 5 consecutive years without a recent review, that is a conversation worth having at your next visit. Number 5 is, in my own clinical experience, one of the most quietly damaging drug classes in older adults: anticholinergic bladder medications. Oxybutynin, tolterodine, darafenacin, fesoterodine, trospium. They are prescribed for overactive bladder and urge incontinence real problems, often deeply embarrassing and absolutely worth treating. But these medications themselves are heavily anticholinergic, and they have been linked in multiple cohort analyses to measurable declines in cognition and, in some studies, to an increased long-term risk of dementia diagnosis. The image I'd give a patient is simple. Imagine a sprinkler system on a lawn, the bladder. Medication slows the flow of water through one set of pipes, the bladder, but it also slows the flow of water through the pipes in your brain, because the same plumbing carries both signals. There are alternatives: structured bladder training, pelvic floor exercise, weight management, timing of fluids, and a different class of bladder. Medication called beta-3 agonists that carries a much lower cognitive footprint. Those alternatives should be discussed before starting or continuing the anticholinergic ones long-term. Number 4 is the gabapentinoids, gabapentin, pregabalin. They are now among the most prescribed medications in North America, used for nerve pain, sciatica, fibromyalgia, diabetic neuropathy, shingles pain, and even restless legs. Here's why they belong on this list. After the age of 60 or 65, kidney function declines. Naturally, sometimes dramatically, even when blood tests look roughly normal and these drugs are cleared by the kidneys. So a dose that was perfectly safe at 55 can quietly become an accidental overdose at 75. The result is often exactly what patients describe as the fog. Words don't come as easily as they used. 2. Driving feels fuzzy. Short-term memory feels unreliable. The patient doesn't feel demented. They feel drugged. And in many cases, that is exactly what is happening. A clearance-based dose adjustment done by your prescriber, never by yourself, often restores clarity within days or weeks, which is precisely why I include this class. On the list today, number 3 is the Z drugs, zolpidem, esopaclone, Zaleplon, marketed as safer, more modern sleep aids, and they are real medications, but they are not benign in older adults. Major geriatric consensus guidance treats these with much the same caution as benzodiazepines, and for very good reason. Seniors metabolize them more slowly, which means morning hangover effects the next day, slowed reaction time when crossing a street or driving, an increased risk of falls and hip fractures, complex sleep behaviors like sleepwalking, sleep eating, or even sleeping through alarms, and most importantly for our conversation today, measurable next-day cognitive impairment that, when these drugs are taken nightly, can look exactly like early-stage dementia. The memory loss isn't dramatic, it is incremental, it is a slow leak, and the patient almost never connects it back to the tiny pill they took at bedtime. Number 2 is the class everyone has heard of but few respect enough: benzodiazepines, lorazepam, alprazolam, diazepam, clonazepam, temazepam. These are the classic anxiety and sedation medications prescribed to older adults in enormous quantities for decades. We now have decades of evidence that long-acting benzodiazepines are associated with cognitive impairment, with falls, with fractures, with delirium, and in the observational literature, with a higher long-term risk of dementia diagnosis. The brain has benzodiazepine receptors the way a car has brakes, and these drugs gently, persistently press the brake pedal on neural activity. Drive a car across town that way. And watch what happens to your reaction time, your memory, and your sense of the road. For seniors struggling with chronic anxiety or chronic insomnia, there are far better supported alternatives: structured behavioral therapy for sleep, certain antidepressants at low dose, retraining of sleep hygiene, careful exercise programs, and they tend to protect cognition rather than dim it. Now we reach number 1, and this is the most important one, because number 1 isn't a single drug, it's a pattern. It's anticholinergic polypharmacy the moment a senior ends up on 5, 6, 7, or 8 daily medications, several of which carry anticholinergic or sedating properties, and the cognitive burden compounds like interest in a savings account you've forgotten about, an anticholinergic bladder medication layered on top of a sleep aid layered on top of a PPI, and a tricyclic antidepressant for nerve pain. That combination isn't rare. It is, in fact, shockingly common, and it is by far the most common reason I see sudden dementia in my clinic. That turns out to be a reversible medication cascade. Antipsychotics deserve a special mention inside this discussion. Medications like haloperidol, risperidone, quetiapine, and olanzapine are sometimes used to manage agitation, sleep, or behavioral symptoms in older adults, particularly in dementia. The FDA attaches a black box warning, its strongest safety warning, specifically about an increased risk of death when antipsychotics are used in elderly patients with dementia-related psychosis, and these drugs themselves contribute to sedation, falls, and worsened cognition. They are not first line. They are rarely the right answer, and when they are added on top of an already heavy medication list, the cognitive picture can collapse fast. So what do you actually do with all of this information? First, never stop a prescribed medication on your own. Cold turkey withdrawal from benzodiazepines, from antidepressants, from gabapentinoids, or from antipsychotics can be medically dangerous, and it is rarely the right move. What you do instead is bring this video or a written list of the 9 drug classes we covered to your next appointment. Ask for what is called a brown bag review. Pull every pill you take into a single bag, including the over-the-counter sleep aids, the allergy tablets, the nighttime cold powders, the supplements, the creams, even the eye drops. Bring the bag to your prescriber or pharmacist and ask them to score your anticholinergic burden. 2. Flag duplicate therapy, and to identify any drug that may be unnecessary or unsafe at your current age and kidney function. Second, if you've started a new medication in the last 3 to 12 months and noticed any cognitive change, and I mean any cognitive change, even a subtle one, flag it out loud. Tell your prescriber, tell your family. Memory loss that begins within weeks of starting a new drug is very rarely Alzheimer's. It is far more often medication-related and frequently reversible if the right adjustments are made in time. Third, ask about alternatives in every category we covered. There is almost always an alternative worth discussing. There are bladder medications with a much lower cognitive footprint. There are sleep strategies that do not depend on Z drugs. There are anxiety protocols that do not depend on benzodiazepines. There are reflux plans. that do not require lifelong acid suppression. You have options. Your job today is to start asking for them. Fourth, please share this video with someone you love, with an adult child, with a sibling, with a neighbor who lives alone and quietly manages a medicine cabinet full of pills they barely recognize. Many of the seniors I see in clinic don't know what their pills are doing because nobody ever told them to ask. You can be the person. Who tells them? Now let me close where we began, because this is the part I most want you to carry with you. Aging is not a sentence. Confusion is not destiny. And in a meaningful number of older adults, the fog that looks like dementia is actually a fog that can be lifted gently, carefully, and with the right doctor beside you. The goal of everything we do here on this channel is to help you keep your memory, your mobility, your dignity, and your independence for as long as humanly possible. Small, consistent conversations with your prescriber. Smart, gradual medication reviews. Honest questions asked out loud before the next refill is filled. Those small actions compound the same way the wrong combinations compound, except they compound in your favor. You are not too late. You are not hopeless. You are not alone. And you are not without choices. I'm Dr. Thomas Reynolds. Thank you so much for trusting me with your time today. If this video helped you, please like it, share it with someone who needs it, and subscribe so we can keep exploring the truths that protect your independence and your mind. Tell me in the comments which of these 9 surprised you the most and which one you're going to bring up at your next appointment. I read every comment, and I will see you in the next one.